Thank you very much for asking me to give this presentation, which is really on decision-making in MIGS case selection, both selection of patients and selection of devices. And I have a number of financial disclosures, which you can see. And obviously there are many new glaucoma procedures, of which those are some. The MIGS or minimally invasive sphere breaks down roughly into Schlemm's canal procedures, of which there are many, subconjunctival drainage procedures, suprachoroidal procedures, of which there's none commercially available at the moment, and some types of ciliary body ablation. As I mentioned, there are two questions really: which patient and which device? It might be appropriate to start off with consideration of in whom our MIGS device is completely inappropriate, and you have to use your common sense here. And obviously patients with uncontrolled advanced glaucoma who really need definitive pressure control with one procedure as quickly as possible and quite aggressively are probably inappropriate. These are the patients who we believe need target pressures of less than 12 and often less than 10, which is difficult to achieve at the best of times. And especially in a young patient, as a young patient, we have to be more aggressive. So we mustn't lose the opportunity to prevent vision loss by wasting time with a procedure that's insufficiently effective. The only real randomized clinical trial that looks at MIGS compared with conventional surgery, i.e. trabeculectomy, is the InFocus or PreserFlow microshunt FDA study INN005. And this shows that even the microshunt, which seems to be the most effective of the MIGS procedures around, lowers the pressure from 21 to roughly 14 millismercury compared to 21 to 2 to 11 with a trab. So you still, even with the microshunt, which is the best, arguably the best or most effective in terms of pressure lowering MIGS there is, it doesn't seem to achieve quite as low as a trab. So I think in patients with very advanced glaucoma, we still have to be using the procedure that's most likely to control the pressure with one hit, and reserve MIGS for less advanced or less uncontrolled glaucoma. However, there are circumstances where MIGS might be appropriate in advanced glaucoma. And in general, if you have someone with advanced glaucoma who has a cataract, who is already very well controlled, then it's probably not unreasonable to offer a MIGS procedure in order to perhaps reduce medication burden or prevent pressure spikes after the cataract surgery. But which MIGS should we use? Assuming, and I'm assuming in this talk that we're going to forward all of them and they're all available, which is obviously not the case in many places. We have the Schlemm's canal stent, such as the iStent and the Hydrus, which are eminently suitable in combination with cataract surgery. But there are a lot of different procedures in this space, the Schlemm's canal space. There are the stenting procedures, there are the cutting procedures. In general, the stenting procedures are elegant, minimally invasive, and we do have randomized clinical trial efficacy data. Cutting procedures are often less expensive, but there is more bleeding, they're more invasive and we still lack RCT efficacy. One might argue that these have similar efficacy because they're all doing the same thing, but the difference between leaving in a stent with not much cutting or not leaving in a stent with a lot more cutting may make a difference to the outcome, and this remains to be shown in trials. Then, of course, there's APGS, which dilates the Schlemm's canal, but again, we don't have RCT evidence. So at the minute, the only hard evidence we have is for the stenting procedures. And the evidence shows that they do leverage the benefit of cataract surgery. On their own, they don't seem to produce massive pressure reductions, but they do certainly produce better pressure reduction after cataract surgery than you would normally get. And I've included both the results of the initial Hydrus study and the G1 iStent study here, which shows the difference between phaco alone and phaco MIGS in terms of the proportion of patients achieving a 20% pressure drop. It's also worth pointing out that for the canal procedures in the US, you can only do them in combination with cataract surgery. If you don't do them with a cataract, you can't do them at all. That's not true in Europe. The contrast, the Zen's different. The Zen can be used either standalone or in conjunction with cataract surgery in the US, but the Schlems canal procedures cannot. In Europe, they're CE marked for everything. So the decision is more in the hands of the surgeon and the patient. So there are differences in licensing that's worth considering. What about subconjunctival MIGS? As I mentioned, in general, they produce greater IOP lowering than canal procedures, but they seem to be less effective than trabeculectomy. And like trabeculectomy, it is believed, although we don't have hard data on this, that they're less effective when combined with cataract surgery. And certainly Santen, the makers of the microshunt at present, I believe, are not recommending combining the microshunt with cataract surgery. The subconjunctival space, there's obviously the Zen and the microshunt. So there's two devices which are very similar, but a slightly different approach. So if a patient is well controlled, needs cataract surgery, we should probably do a canal procedure rather than the subconjunctival MIGS. But if they're uncontrolled, probably the subconjunctival MIGS comes into its own, with the caveat that they don't seem to produce the pressure drop quite as much as trabeculectomy, so are perhaps not appropriate for the very advanced glaucoma. On the other hand, the subconjunctival MIGS are less invasive with quicker recovery, and patients will like this. And this again is, I'm repeating the earlier slide showing the showing the 1 year data after the INN-05 microshunt study, showing that you can get a pressure drop to around 14 mils mercury with a microshunt. Not quite as low as 11 with trabeculectomy, but it's still fairly impressive. One might point out that in this study, we used 0.2 milligrams per mil of mitomycin, whereas with microshunt implantation in general, we're now using 0.4, 0.5, which seems to give better pressure control. So this probably underestimates the effect of the microshunt, but it's still, trabeculectomy seems to win in terms of pure efficacy. This is a very speeded up video of the microshunt for those who have are not familiar with it. And it's a fine polymer tube that drains aqueous to the subconjunctival space. Most of you are already familiar with the Zen, which is an ab interno approach. The microshunt is an ab externo approach, although the ab externo approach does look initially very similar to trabeculectomy, and you may think, well, this is not very minimally invasive. After you've done the mitomycin, really, from then on, it's nothing like a trabeculectomy. And you will see here that like a Zen, the key mark is 3 millimeters behind the limbus, except again, you're going in ab externo rather than ab interno. The 1 millimeter slit keratome and needle are provided in the package with the microshunt. And you've got to be quite careful not to distort the tissues. This looks very simple, and it is quite a simple technique, but there are a couple of tweaks to ensure that the microshunt doesn't sit on the iris or in the cornea. And it is self-retaining because the flanges are slightly wider than the width of the tunnel. Unlike the Zen, it's hydrophobic, and you do need to make sure it flows on the table before you close up. If you don't have flow visualized during surgery, then the microshunt won't work. And you've got to make sure it's not closed with it doesn't get blocked with tenons. The ab externo approach facilitates placement and makes it easier to avoid getting tenons in it. Whereas with the Zen, as you know, there's some postoperative manipulation to try and avoid tenons blocking it. And this produces a very diffuse posterior bleb. Because it's a longer tube, the bleb starts 6 millimeters back from the limbus. So they are quite contact lens friendly as well. What we also need, as I've highlighted, is much better comparative data to give us a better idea of which procedures we should be using. Large data sets have taught us an enormous amount about cataract surgical outcomes. Glaucoma surgical practice is far more diverse than cataract surgery, yet no comparative outcomes are available across the spectrum of glaucoma surgical procedures. We've tried to remedy this with our International Glaucoma Surgery Registry, which provides for the surgeon a free personal audit of their individual results versus a large data set. A data set, a rough comparison of outcomes across all types of glaucoma surgery. It provides something that individual companies with new devices can use for regulatory purposes, and hopefully comparative patient-reported feedback across various types of glaucoma surgery. And this has been adopted by the European Glaucoma Society. And we currently have around, after 2 years, we have around 3,500 patients. So it's a relatively new database. And it gives you very visual printout and audit report of your outcomes. And you can get a free login at either eugs.org/registry or simply igsr.org. And thank you very much for your attention.